Welcome to the fourth session of the webinar series on genetic services in Appalachia. We ask that you mute your microphone for the talk and place any comments or questions in the chat. We ask that you not record our session. We will be recording the session and providing a transcript on our webinar website. And we had a little bit of delay due to the holiday and some illness for our third session, but those should be posted by the end of the week, if not in the next day or so. At the end of the session today, we'll ask you to complete an assessment to give us feedback. And we sent around, for those people that are registered, we sent around information on an evaluation for our last session. So we ask that you please provide that if you are able. And as you know, for this survey, genetic services in Appalachia seminar series, our aims include to develop a research agenda for genetic services in rural Appalachia. Each month, we'll be having speakers who are working in genetic service provision in medically underserved populations, most of them being in the Appalachian region. And our ultimate goal is to develop a research focus to improve the quality of care in genetic services in Appalachia, and also, to the extent that we can in West Virginia. So we've had 3 sessions so far, and those are available on our website. But now I would like to introduce Ms. Alyssa Bovee-Terry. Ms. Terry is a genetic counselor in New York State and has been working with the federally funded NIMAC, New York Mid-Atlantic Caribbean Regional Genetics Network, for the past 6 years. And she will talk to you more about what that is and what exciting opportunities they have for us. Currently, Ms. Terry serves as a project director and telegenetics navigator for NIMAC. Ms. Terry received her BA in biology from Cornell University and her Master's of Science in genetic counseling from Johns Hopkins University. Ms. Terry has worked in various capacities for the genetic counseling program at the FAIR Institute since 2006. So at this time, Alyssa, if you would like to share your screen, we would be thrilled to learn more about your NIMAC and the work that you're doing, especially in telegenetics and genetic service delivery to underserved populations. Thank you.
Perfect. All right. Well, thank you so much for that introduction. I look forward to being with all of you today and sharing some information about our organization. I do not have any conflicts of interest. As Kim just said, I do work under a federal grant from HRSA. So as you saw, NIMAC stands for New York Mid-Atlantic Caribbean, and our region includes 10 states and jurisdictions, which I'll discuss further. NIMAC is one of 7 federally funded regional genetics networks, and we all aim to ensure that individuals, especially from underserved communities with genetic conditions, as well as their families, have access to quality care. You can see the map in the website here. The regions are further supported by the National Coordinating Center at the American College of Medical Genetics and by the Family Center hosted at Genetic Alliance. The system of RGNs collaborates broadly with genetics groups, training programs, and importantly, also family and support organizations. Okay. So in a nutshell, what NIMAC does with our grant funding is to try to improve the genetics delivery system by collaborating with all types of diverse stakeholders, to make telemedicine projects, to make it easier for families to get the care they need without travel. And we do education about genetics for both families and professionals. And again, all with the aim to achieve access to quality genetic services for people with genetic conditions and their families. And today we are going to focus on our work around telemedicine and telegenetics. So as I mentioned, the NIMAC region includes 10 jurisdictions, which vary a fair amount in size and makeup, as you can see here. We do have a very long history of working with West Virginia University, so we thank them for their ongoing collaboration. And as we'll see in the next slide, there's a lot of overlap between the NIMAC region and the Appalachian region. So 5 of the 10 NIMAC states have portions of the state that are considered parts of Appalachia. The other states in the Appalachian region are included in some of the other regional genetics networks. So if you're here listening today and you're not in a NIMAC state, I encourage you to locate your regional genetics network and learn about their similar programs. As we probably all know, one of the biggest challenges in the Appalachian region is the lack of medical providers. You can see here how much of the region is considered to have a shortage of healthcare providers. This is certainly true for the shortages of genetics providers across the region as well. Similarly, if we're all likely pretty familiar with the challenges across the region with poverty, again, you can see the tracking of poverty levels with some of the largest areas of poverty in the Appalachian region. Clearly, these communities will have a more challenging time obtaining adequate healthcare. The pattern of genetics clinics across the region is pretty stark, with clinics densely located in urban centers near New York City, Philadelphia, Pittsburgh, DC, Baltimore, and Richmond. While there certainly are genetics clinics in other parts of the region, many families do have to travel pretty substantial distances to reach them. So the challenges that many families in our region face in getting to a genetics clinic was a big motivation for us to start exploring and supporting telegenetic services about 5 years ago. The visuals you see here were developed by families in our region to explain telegenetics to other families. You can find the infographic at the link on the slide. When I'm talking about telegenetics, most people think about live video meetings, and that often happens, but sometimes telegenetics happens over the phone. Sometimes records and documents are sent to a provider without a live meeting, and we call that store and forward. And sometimes a doctor will keep track of a person's signs and symptoms and send that information electronically for evaluation, and that's called remote patient monitoring. And finally, when communication happens on mobile devices by texting or apps or video messages, that's called mobile health. With the overall goal being to expand access, we see from studies that telegenetics can improve patient access and reduce cost and wait time and travel. Even before COVID, we were able to see that there were a lot of telegenetics programs in the NIMAC region and a lot of interested genetics providers. Clearly, telegenetics was very important to maintaining care during COVID. But if we're going to think about any kind of telehealth, we also have to look at what resources families have available to them. Telehealth can be a challenge when broadband or cell phone coverage is not good, as we see across the region in certain areas. This is really important to keep in mind when you're trying to use telehealth to reach families that already have challenges in accessing care and services. So in 2016, we saw that every NIMAC area had telegenetics at that time. Telephone calls were often excluded at the time from the definition of telemedicine. Most of the telegenetics at that time was done by live videos and occurred in a variety of settings. Sometimes it was from one clinic to another clinic, so maybe a primary care provider's office to the genetics office. Sometimes it was from the clinic to the patient at home, which we're seeing more frequently now. Some of this is provided by telegenetics companies. Some of this is provided by the laboratories that offer the genetics testing. And sometimes it happens, as I mentioned, by providers communicating with each other instead of a patient and a provider working together. And NIMAC has really played a role in supporting some of these clinics and models of care, and we aim to engage with all of them. In the summer of 2020, we explored patterns of telegenetics use across the region, and not surprisingly, saw there was a big shift from mostly doing in-person visits to mostly doing phone and video visits during the COVID pandemic. At that time, most providers, about 60%, said that they did plan to continue using telegenetics even post-pandemic. There are always barriers to new models of care. It's interesting to look at what got in the way of providers using telegenetics before COVID as compared to after. We can see in particular that there was a big shift in lack of provider interest, patient interest and time, and institutional support being big barriers before COVID, but not barriers after COVID as we all shifted to using telemedicine. NIMAC has aimed to support the providers that wish to use telegenetics in a number of ways. We offer technical assistance, we offer education and training about telegenetics, and we also offer collaborative funding. On the whole, we've seen big successes with our work. We've been able to impact a lot of providers and families, with a total of about 20,000 families having been seen by telegenetics in NIMAC supported clinics since 2018. We have provided one-on-one direct assistance to over 150 providers. We work closely with our partners at the federally funded Telehealth Resource Centers, which I'll provide some more detail on later. We also have a telegenetics community of practice. These are providers that we started to identify in 2016 who had a special interest in telegenetics. We try to offer special education opportunities as well as collaboration for these providers and bring them together at our annual virtual meetings each year. We have trained over 80 genetics providers and students in collaboration with partners in the Western States Network. This training is now fully online and offers free CEUs and CME. And here's some more detail about that training opportunity if anyone is interested. It was all updated in 2021 and includes 10 modules and a 4-hour live Zoom meeting. You can email me directly with any questions about that provider training. So in addition to that training, NIMAC offers other educational opportunities related to telegenetics at in-person meetings such as NSGC and ACMG. We do a lot of webinars and virtual meetings just like this one, including the annual NIMAC meeting. We post resources about telegenetics on our website, Facebook, YouTube, and other locations. So I encourage you to check those out as well. Here are a few examples and links to some of the telegenetics education events that we've done. We do have extensive resources on our website, as you can see on the left. We have some recorded events that are still available. And we also cover telegenetics in all of our annual meetings. Our meeting last year is fully recorded and available. And this year, our meeting will be April 5th and 6th. NIMAC also has a toolkit to support planning a telegenetics program. The online toolkit includes a guide, resources on the website, a fact sheet about technology, a progress survey, and an introductory webinar. The toolkit is derived from the work that the Heartland's Regional Genetics Network did, as well as the California Telehealth Resource Center. We've really boiled it down to 7 steps that gives extensive examples and templates for people who are planning. We used a lot of input from our partners at the Telehealth Resource Center, and we provide a checklist to help people track their progress. The plan outlines 3 phases, which consists of 7 different tasks. In the first phase, it's really focused on assessing and defining. So you're assessing service needs and environment, defining the program model, and developing your business case. In the second phase, you're more in development. You're planning your program and your technology, and you're also developing performance monitoring, evaluation, and quality improvement metrics. And then finally, in the third phase, you're really implementing and monitoring your work. So you spend some time implementing the program and then continually monitoring and improving. We also have a planning checklist to benchmark progress. It's based on the steps in the planning guide. At the beginning, you get basically a baseline score, and then you can track and quantitate progress throughout your planning process. Here are some examples of the progress we saw in clinics pre-COVID. You can see that the trainees that received funding from us made a ton of progress in their program planning. I'm not going to go through each step of the planning guide today. You can see notes on each step at the ends of these slides, but I was asked to spend just a bit more time talking about the financial models for telegenetics. So when thinking about the financial models, you really want to include your financial risks and constraints, both at the patient site and at the site of the specialist, the genetic specialist. You want to describe the market and the demand for the service and how much uptake you expect. So do the patients really want this? Is this something that they're interested in and very likely to utilize if it's offered to them? You want to be able to describe all your funding sources. So obviously patient insurance billing options, but also opportunities you have for grants, for direct billing to patients, and through contracts. You want to be able to outline your cost estimates. So there may be some startup technology costs, new operating costs if new staff has to come in. Also any new facilities, marketing that you might have to do. But it's also important to note your expected cost reductions. So especially for a program that is going to start using genetics that maybe wasn't doing it before, we see oftentimes the implementation of this type of genetics program results in better utilization management with ordering of genetic tests being more appropriate and efficient, and a reduction of errors. You also want to outline your revenue expectations, what you imagine the program is going to bring in, both in terms of billing for the actual services, as well as the downstream revenue to the facility that can result in identifying patients with genetic conditions that need further care after their diagnosis. You want to be careful to project beyond what's going to happen right away and really think about growth in your financial model. And finally, sometimes calculate a return on investment. With all that in hand, it's useful to develop a business report or summary that you can share with your stakeholders, and then to really invite feedback from those people. Some of the resources that we provide in our toolkit related to this are an insurance reimbursement fact sheet, information about how to calculate a return on investment, as well as a federal grant fact sheet and a budget template. Some examples of the payment models for telegenetics. This is definitely not an exhaustive list, but obviously many programs do bill insurance for their telegenetic services. This can be done oftentimes by using the professional codes and just using a telemedicine modifier after the code. So there are some CPT codes that can be used, such as 96040 with genetic counselors. This type of billing is often pretty straightforward for physicians and often for PAs and nurse practitioners as well. I will note that genetic counselor billing for telegenetics is often based on how the institution bills for similar in-person services, if they offer both. Because genetic counselors are not recognized by Medicare, that means that some institutions do not bill any insurance companies for genetic counseling, even though some private payers would pay those codes. This typically impacts the way the institution is willing to bill for telegenetics also, and sometimes prompts a review and change of all genetic counseling billing strategies. Facility fee and incident to billing, which are often used for in-person care, are typically not applicable to telemedicine, although sometimes a distant site facility fee is allowed. Some payers will pay an originating site fee. So if a patient comes into a clinic to connect to the genetics provider in a different location, sometimes there's a fee that can be paid to their primary care clinic or wherever it is they're coming in. And lastly, providers may sometimes assign their billing rights to another site and allow them to do the billing. So there's an occasional situation where your genetic specialist could hand over the billing rights to the primary care office, and that's who would do the billing to the insurance. That's a bit more complicated system, but we do see it used sometimes. So other than insurance reimbursement, another model we see is contract models. This is where the specialist is paid by contract from another group. So this might be an oncology group, an MFM group, a cardiovascular group, who pays a genetics group, a genetic counselor, a geneticist, in lieu of having to employ their own full-time staff member as a genetics provider. The paying group benefits from having better patient outcomes, gaining eligibility for credentialed center status. So sometimes oncology settings, for example, want to be credentialed by some of the broader oncology credentialing services and have to have some sort of genetic service available to meet those guidelines. It also helps keep patients local. And as I mentioned before, having genetics involved in some of these specialties really does reduce errors and increase downstream revenue. Sometimes in these contract models, insurance is billed, and sometimes that is related to what I mentioned before with assigning the billing rights. And some genetics providers do freelance work under these types of models, and there are a number of telegenetics companies that work under this type of model where the genetics provider is not affiliated with a hospital or institution, but does contract work related to other centers that need some level of genetic services, but not a full-time employee. In the world of grants, there is a lot of grant funding available right now for telehealth. Many telegenetics programs do get started using grant fundings, but we always encourage people to try to plan for sustainability and not be relying on those grants long-term. And lastly, patient pay. So some telegenetics programs really rely mostly on direct billing to the patients outside of insurance billing. We do see that happening. It's not the most preferable model, certainly, it's especially in underserved communities, but it is one of the kind of core options that we see telegenetics services using. This type of billing is usually pretty straightforward for physicians and often also for physicians' assistants and nurse practitioners. So they kind of take the code that they would have used if they were seeing the patient in person and just add a telehealth modifier to that. So it can be pretty straightforward for the most part for those providers. Genetic counseling billing for telegenetics is often influenced by how the institution bills for in-person services if they have both. So because genetic counselors are not recognized by Medicare, some institutions never bill any insurance companies for genetic counseling, even though many private payers do pay genetic counselors. So if that's the case, that typically impacts the way the institution is willing to bill for telegenetics. So basically, we always tell people if your institution is not billing for your in-person care, they're probably not going to start billing for telegenetics. But what happens is sometimes this question really prompts the institution to go back and look at why they're not billing for their in-person genetic counseling. So the two are, if the clinic offers both in-person and telehealth, the way you bill is typically aligned between the two practices and influenced by the choices that were made about in-person care. Facility fee and incident to billing are used a lot for in-person care, especially with genetic counseling, and are often not applicable for telemedicine, although in some situations a distance site facility fee is allowed. Some payers will pay an originating site fee if a patient comes to a clinical site. So if they walk into their pediatrician's office, there are some insurances that'll pay the pediatrician's office a small amount of money for their sort of assistance in that effort. Providers may sometimes assign their billing rights to another site and allow them to do the billing. So you might have a geneticist at West Virginia University who's doing some care, and instead of West Virginia University doing the billing, they assign their billing rights to, a maternal fetal medicine clinic, and they just do the care. And the maternal fetal medicine clinic pays the geneticist by contract, but they don't actually bill the insurance. That's sort of a complicated way of arranging things, but it does exist sometimes. So outside of insurance reimbursement, we do see contract models where the specialist is paid by contract from another group. Again, we're thinking about maybe an oncology practice, maternal fetal medicine, cardiovascular center. And it's usually a substitution for those places having to hire their own genetics provider. So the paying group, say the oncology center, benefits from better patient outcomes, from eligibility for credentialed center status. So there's some national credentialing sort of titles that you have to have the availability of genetics in order to qualify for. So sometimes that's why an oncology center would be seeking a genetics provider. It helps keep patients local, reduces errors, and again, generates downstream revenue, as I talked about before. In those contract models, sometimes no insurance is billed, and sometimes this can be affiliated with assigning billing rights, like I mentioned before. Some genetics providers do freelance work under these models, and numerous telegenetics companies exist that work under this type of model. again, where the genetics providers don't work for a hospital or a health system, but rather just do telehealth under a contract. Thirdly, a lot of grant funding is available right now for telehealth because of the COVID pandemic and the importance of telemedicine then. So there are a lot of programs that have benefited from obtaining some of that grant funding. It's a great way to get started, but we definitely encourage centers to plan for sustainability over time. And lastly, some telegenetics programs rely mostly on direct billing to patients. So they don't bill insurance, but expect families to pay directly, which obviously can be a big barrier. So a few final notes about planning. Planning a program can be pretty complex and lengthy, or if a pandemic happens, it can happen very fast. Our planning guide hopes to provide structure, support resources, and a checklist to our genetics providers. We are available to support providers through the process, and we encourage our regional providers to contact us for more information. So lastly, we're happy to be able to provide funding to some groups for telegenetics. We're now up to 11 groups that we have awarded telegenetics funding to, and we do see big increases in their planning scores and many patients seen by those programs. We have funded or have plans to fund programs in every single one of our jurisdictions and try to make sure that those programs are specifically reaching underserved communities. And we're lucky to receive great feedback from some of the groups we have worked with. You can see some of the lovely things that people have shared with us about NIMAC support, especially during the transition to telemedicine during 2020. So we're really happy to know that the support that we had provided to our genetics providers and clinics really helped them make that transition more quickly than they maybe would have been able to do had they not been engaged with us. So as I mentioned, NIMAC is part of a nationwide system of regional genetics networks, and all of those networks provide support for telegenetics. Here you can see the work that's been done nationally over the past 3 years with regard to telehealth training at the top, education in the middle, and technical assistance on the bottom. So this is happening not just in our region of NIMAC, but across the country with all the regional genetics networks doing this type of support. And as you can see here, there has clearly been a huge jump in patients seen by telegenetics in the supported sites across the nation. We're glad to see that a lot of those families are indeed coming from medically underserved areas. So I also want to make mention of some of the other work that NIMAC does that touches on telehealth in some way. We are in the process of establishing teams in each of our 10 jurisdictions. These are made up of diverse stakeholders, and we have a great team in West Virginia that some of the people on the call today are in. And I think I saw somebody from our Maryland team on today as well. I thank you guys for being here. So these are teams that are set up eventually in each jurisdiction to help us understand the key barriers and solutions to improving access to genetics in the state. So each NIMAC team defines their own local challenges and potential solutions. Thus far, our work on the teams has produced an infographic and social media campaign in New York, an educational program for existing staff that work with families in Virginia, and a family video testimonial project in DC. Some of the NIMAC teams may choose to focus on telegenetics if they deem that to be the most relevant issue to their state at the time. NIMAC also includes the territories of Puerto Rico and the Virgin Islands as of 2020. We're working on very similar goals there. And due to staffing shortages and obvious challenges to traveling for care, a key goal in the territories is also to design a culturally effective model for telegenetics. So we have been aware that we need to design things pretty differently there than how telegenetics works here. But we're hopeful, and we're working closely with some amazing people there to see what we can do to improve access to care in the territories. This is our NIMAC flyer, which outlines all the programs that I have talked with you about today. The link is on the side of the slide there. You can find it easily on our website as well. And I just wanted to share a few other notes about really useful resources. So as I stated, the other regional genetics networks have great resources for telegenetics as well. The Southeast region has a telegenetics work group. The Midwest has some great patient telegenetics videos. Western states has a huge collection of videos, online resources, and the training program. The Family Center has that infographic that I shared earlier, and our national group has a full resource repository that includes these telegenetics products. These are all freely available, and I encourage you to explore them. NSGC and ACMG also have a lot of support and resources for telegenetics. Both organizations are currently working on publishing recommendations for telegenetics. They include telegenetics in their education planning and supply a lot of resources. So I encourage you to check there as well. Some clinics have incorporated other technology beyond telegenetics, including things like chatbots to answer questions, online family history collection tools, various databases and risk calculators, and even using artificial intelligence in some settings like facial recognition to predict potential diagnoses. So sometimes these health IT applications are integrated into the telehealth program. Sometimes they're sort of a side project that goes along with both the in-person and the telehealth, but it's been really interesting to see the evolution of these other technology applications in genetics. It's also key to point out that the family engagement is vital to planning and implementing telegenetics. NIMAC and the other regional networks all emphasize family engagement and were greatly supported by the Family Support Center. We have definitely seen that the more the new strategy is informed and tailored by the community, the higher the likelihood of success is. And that's very true for us in our work in the territories we've noted. And we're doing a lot of work in West Virginia right now too. So lastly, I'll share some other really good resources for telehealth in general that are not built specifically for genetics, but can still be very instrumental. So the Telehealth Resource Centers, as I said, are also federally grant-funded organizations. They provide assistance, education, and information for anyone interested in providing care at a distance. The Mid-Atlantic Telehealth Resource Center covers Virginia and most of the NIMAC states, but there are different telehealth resource centers that would cover some of the other Appalachian states. They do offer a number of fact sheets, online resources, office hours, annual meetings, and online forums. And I have the link there that you can either find Matrix if that's your home telehealth resource center, or using their map, you can find yours. The Center for Connected Health Policy serves as an independent center of excellence for policy. They provide technical assistance to all of the other telehealth resource center. So they sort of keep track of and organize all of the state laws and local policies that influence what can and can't be done by telehealth. And we're gonna take a look at that on the coming slides because it's ever evolving, as you might imagine. And lastly, TTAC is also federally funded, and they kind of keep track of and assess new telehealth technologies. So they often review things like if a new electronic stethoscope that can be used over telehealth comes out, they might check it out and do sort of a short video on how it works. So you can go on there and sort of look at their reviews, their innovation watches, and they provide assistance to organizations that are trying to make purchases or selections in making choices between telehealth products. So again, telehealth policy can be really important, and telehealth resource centers, as well as the American Telemedicine Association, do a great job of keeping track of those policies. So just some of the things that can influence the way you build a telehealth program will include state licensure policy. So typically, a medical provider needs to be licensed in the state that the family is located while they're talking to them. That only applies if there is licensure for that profession. So there is no licensure for genetic counseling in some states, including West Virginia. But for physicians, for example, if they want to talk to a family that is in Pennsylvania and the provider is sitting in West Virginia, they oftentimes need to have a medical license in Pennsylvania. On the next slide, I'll talk a little bit about how that changed during COVID. Similarly, A lot of telemedicine requires credentialing at other institutions. If you're going to connect one clinic to another, sometimes your specialist, your genetic specialist, has to be credentialed at the other institution. Medicare has some very specific rules about who can do telemedicine and how it needs to be done. Again, a lot of those rules were relaxed during COVID, so we'll talk a little bit about that on the next slide. A lot of state Medicaids have their own separate policies, so they don't necessarily align with what Medicare says. They have their own set of rules about both who and how telemedicine can be done. The private payers may have their own set of rules about what they will reimburse in terms of the codes and the types of providers. Some states have specific consent policies that if a family is receiving a telehealth consult, they have to have a specific consent just for the telehealth visit, so above and beyond the consent that they're providing for treatment. There are privacy and HIPAA regulations that need to be kept in mind when you're doing telehealth, and also fraud, use, and abuse policies. So certainly nothing that I say, and the Center for Connected Health Policy also says this should never be considered legal advice, but it's useful to keep in mind the various types of policy that would impact a planning process. So we have seen a lot of policy changes with COVID and the need and demand for telemedicine solutions. So there were changes over time in that previous policy, including Medicare, used to require that families that receive telehealth had to be located in a rural location. That has changed, at least temporarily, so that pretty much all patients are eligible to receive telehealth regardless of where they live. The type of site that the family was in when they talked to their specialist used to be limited by Medicare to only clinical sites, so the patient could not be at home, with a few really specific exceptions. Again, that's changed during COVID, as we all know. A lot of families have received telehealth at home. We don't know what the long-term policy is going to be there, but as I said, the previous Medicare policy did not allow patients at home to receive telehealth and be reimbursed for that. The codes that were billable for telehealth used to be much more limited than they have become now during COVID. So when you're thinking about billing codes and what is happening with the patient from the hospital perspective, there's a lot more eligible codes now. Similarly, in some situations, there were only specific providers that were allowed to provide telehealth. So maybe in some places only physicians could do it, and none of the nurse practitioners or PAs or genetic counselors or anybody else could do telehealth. And we've definitely seen that expand. States oftentimes have specific policies requiring their payers to pay for telemedicine. We've seen that increase over time, and that you can check your state on the Center for Connected Health Policy with regard to that. We've also seen during COVID a relaxing of the rules around HIPAA and consent. So there's no explicit HIPAA policy that's just about telehealth. It's really just about making sure that your telehealth system maintains the same confidentiality that you would have in person. But we have seen, certainly during the very height of the pandemic, doctors much more likely to use their cell phone to do a video call, sort of whatever it took to get care to the patient. So we did see that relaxation happening. I think most people expect it to go back somewhat to be a little more rigid, but I think a lot of expectations are hopeful around continuing to have a little more relaxed rules around these things. Similarly, I talked about medical licensure on the last slide. A lot, I would say most states had very relaxed policies, at least at certain points during the pandemic, with regard to whether or not a provider who's talking to a patient in their state needs a medical license there or not. So for pretty long periods of time, our providers from Maryland could talk to a family in West Virginia or in Tennessee or wherever the family was without worrying about whether or not they had a license in that state where the family was. I don't think most people expect that to be an immediately permanent thing. There are some interstate licensure compacts that are being explored that would make it a lot easier for providers to hold multiple licenses. But it's certainly something that you always have to keep your eye on. If you're talking to a patient in another state, you need to know what the existing current policy is on whether or not you need a license there and if there is licensure there. There were some relaxed rules about whether you could prescribe certain medications by telehealth, as well as around fraud and abuse. We don't really know what the future will look like. I definitely rely heavily on the Center for Connected Health Policy. You can go right to their website, find your state, and find out what's going on. They keep track of policy that is being proposed. It's important for all of us that are invested in telehealth to play a part in supporting policies that will make things easier for families. So I think we're all sort of just watching and waiting to see what will become permanent and what might revert back to the way things were pre-pandemic. So a couple other resources while I wrap up. I mentioned the American Telemedicine Association before, but here is a link to their website. They also have annual meetings and a lot of resources. They are a membership-based organization. Some states or regions have telehealth groups that really watch closely and advocate for policies in the state. The American Medical Association has resources for telemedicine practice, as well as the American Academy of Pediatrics specific support resources. So that's really it for me. I really thank you for your time today. I encourage anyone in the NIMAC region to please consider joining us, to use our resources, to tell other people about NIMAC, attend our events, use our website. I encourage you to reach out to us if we can be helpful in your work. And with that, I'm going to thank you for your time today, and I am happy to answer any questions.
Thank you for that wonderful presentation. And my mind is buzzing and trying to process all of the different sources of information and all the potential directions that we can go in telegenetics. So thank you for that. And I'll also mention that Alyssa has been very engaged with us in at WVU in trying to learn more about our population needs, and has been doing some work in collecting information and trying to figure out how to best provide services, genetic services in our region and in West Virginia in particular. So I'll kick us off with a couple of questions, and then anyone else that has questions, we'd be pleased to field those. First, knowing your background and talking to lots of folks in our state, what do you see as the primary challenge for genetic services in rural Appalachia?
It's interesting. We, as an organization, we have started recognizing that we see three very common themes whenever we talk to any location that we work with. So we see themes under the bucket of distance to care, sort of where you are versus where the closest clinic is, and how you get from A to B, even if you're within the same city. Sometimes those issues can be really important. So distance to care is one really big one. We also see issues related to education about genetics. So whether the family has sort of enough health literacy to understand the value, if they're recommended to go to an appointment, they might it's not on their radar as a priority. And some families do have really important competing priorities. So we see education barriers both for the families as well as some of the providers in the community. So if it's the pediatricians or the primary care providers, just maybe not prioritizing genetics. So sort of that education bucket. And then the third is we typically see unique issues for each underserved community that we look at. So as you said, we've been looking really closely at West Virginia. We worked last year really closely with Virginia and DC and New York. And every time we have those conversations, there tends to be just really specific, unique issues that arise for people in that specific population. We work with Amish and Mennonite families in Pennsylvania that obviously have really different barriers to care than other families. So a lot of the work that we do is really to keep trying to collect experiences and stories from across the state to understand what that is. And I don't, it's never going to be possible to design a genetics healthcare system that optimally addresses all of those problems. But I think we can all explore ways to be more flexible in the way clinics provide services, to participate in community-based and provider education just to raise awareness about genetic services. The issues around bringing providers into the state, I think, is a problem probably across a lot of the states in Appalachia, just not being able to fill genetics provider positions or fund genetics provider positions is a huge barrier. And I think a lot of the professional organizations are trying to provide resources to convince institutions to have more positions for genetics. And I think sometimes the advent of telehealth also allows some of those positions to be filled by people that, providers that aren't ready to permanently relocate. They can still provide some of the services by telehealth. So I think those are similar to the other areas, those issues of distance, of issues in underserved populations, and of education tend to be the biggest things that we try to address.
Yeah, and I think health literacy is a big one in Appalachia. I would agree. I mean, I grew up in more western part of Kentucky, and my family is from Appalachia, but I had never heard of genetic counseling until I went to graduate school and started working with the BRCA mutations. Yeah. And my family has cleft palate, and they, were had some financial challenges. So I think it is a big issue, just knowing that there's someone that can handle these kinds of issues, and so that's something we're also working against.
Yeah.
Another question is, what are some of the opportunities you see for research to improve genetic service delivery in West Virginia and the region? So you talked about some of the other things that are going on, and certainly Dr. Fala has talked a bit about her work, but if you can just comment on that.
Yeah, and I think as we're typically not a research organization, we're less tuned in, but need to be more tuned in. So when we're talking about these solutions that we try to build, for example, if we're trying to improve the health literacy in a community in a way that would impact the likelihood of a family going to genetics, those are things that can be tracked and followed. If you're going to do some sort of health literacy campaign, let's try to find a way to keep track and to measure whether or not that actually improves compliance in families taking up the referrals that they're given. As you mentioned, we've seen even families that do receive services don't always follow through on the medical recommendations. So I think there's ways to look at interventions in that arena. What can we do in clinic to remind families, to make it more likely that they're going to follow through? So I think all these interventions that we talk about, even if it is something as simple as a social media campaign, we need to be cognizant of finding ways to keep track of whether it's actually working and making an impact, because if it does work, those are programs that can be expanded more broadly. If that doesn't make an impact on making it more likely that families are going to get into care, then we shouldn't keep investing money in doing those things. I think there's obviously been work done over the years in demonstrating the value of having a genetics visit for a family. Like you mentioned, if a family has a history of cleft palate, what is the value for them in going to a visit? But maybe that needs to be studied more specifically in the region, just to be able to demonstrate really concretely why it brings value to the system and to the family for them to go to care, to sort of convince institutions that it's worth it, both to the institution and to the family. A lot of times we do see genetics providers or even genetics clinics being on paper looking like they're kind of losing money for the institution because of the billing situation. But a lot of places are able to document that there's all these other impacts on families and downstream with the institution that argue for the value of genetics. So I think for places that are really struggling with having enough genetics providers or having institutional support for genetics providers, maybe taking a look again at really documenting and demonstrating why it matters, what impact it has, and how it does benefit the institution, even if it's not in the immediate billing cycle.
Thank you. Does anyone else have any questions for Ms. Terry? Okay, and certainly if you have additional thoughts, we have an evaluation, and Anusha, if you could post that in the chat, and we would appreciate your feedback about this. If you have additional questions, you know, we're working with Alyssa a lot these days, and appreciate the good influence she's had on increasing service provision in our state. And it sounds like other regional genetic networks are doing great work in that area as well. And I certainly am indebted to the progenitor, I guess, of NIMAC, which was Margin, and that helped me set on this path. But if there are no additional questions, I'll thank you, and we will be in touch.
Thanks so much.
Thank you. Oh, wait a minute, there's something here. Let's see. Regarding added value, there's one comment from Dr. Kaler.
Oh, that's great.
Yep, that's how you pronounce my name.
Well, thank you. That's always
great.
encouraging.
Yeah. Of course, the money was spent by genetics and surgery and radiology, not the income.
Yep. Exactly.
But yeah, the more targeted we can get in our approach to helping people, where we're not having to, you know, run a lot of different types of tests, and we can kind of zero in, that certainly helps too.
Oh, that saves a lot of people money.
Yeah.
Mm-hmm. All right. Well, thank you very much. We appreciate your engagement.
Nice
today.
talk. Thanks so much.